Hello, everyone. We're just going to welcome, and we're just going to wait for a couple more minutes for people to sign in, and we'll start the webinar.
Whoops, I don't want to do that.
Welcome, everyone, to today's webinar, Case Management and Transitions of Care, the latest in a series of programs focusing on transitions of care and specifically Project RED, Re-Engineered Discharge, and the scientifically derived and validated principles of Project RED, which reduce the risks and costly errors from ineffective transitions of care. With Dr. Brian Jack, who created Project RED, Elizabeth Ziemba and I have developed Project RED Solutions, a consulting firm focused on implementing Project RED in healthcare systems in the US and around the world. Dr. Morley recently joined our team. We are convinced that improving transitions of care in better results in better patient outcomes, happier staff, plus more effective and sustainable systems. Project RED principles improve safety and care quality, increase efficiency, and reduce risk through adhering to best-in-class standards. Project RED Solutions delivers training, implementation consulting, and measurement for better transitions of care. To learn more about Project RED Solutions, access webinars, and other resources, please visit our website, projectredsolutions.com, or contact any of us after the webinar. In our last webinar, we looked at the challenges of transitions of care in international medical travel or medical tourism markets. Today, we are delighted to have Dr. Colleen Morley, who will cover how Project RED principles mesh with traditional case management principles in these transitions of care. It's one thing to know the principles, but it's quite another thing to apply them. How do we do this? And that's what Colleen will review. Colleen Morley is Associate Clinical Operations Officer for Continuum of Care at the University of Illinois Health Sciences System. She is the president of the Case Management Society of America, where she also sits on the National Board of Directors. Dr. Morley has published the seminal textbook in the field of case management. I have an autographed copy, and is widely published, and just today published a practical guide to hospital readmissions reduction, which is available on Amazon, and we expect that everybody here will rush and crash the Amazon server ordering their copies. She's an experienced case management leader and a passionate educator. We are truly fortunate to have Colleen with us today. Before I turn the virtual mic over to Colleen, I want to encourage the audience that you can add your comments, questions, and observations into the Q&A box in your screen. We will have time at the end of the presentation for your questions, so please do add them. Thank you, Colleen. The digital stage is yours.
Thank you, Irving, and thank you, Emily, for manning behind the scenes. Greatly appreciate this opportunity. I've worked with Project RED in one form or another for over 15 years, since 2009. It was one of at my very first director of acute care case management positions, we were talking about readmissions. Readmissions had just become the new buzzword back then. And oh my God, what are we going to do about the readmissions? And we were fortunate enough to get a grant to be able to work with the Project Red team and bring that into the system that I was working in, and looked at the Project Red principles and really understood, that they did indeed live in the case management arena, not just only in the case management arena, but case management could certainly champion the implementation and watch the management of it and, be the drivers behind it. It's a multidisciplinary, interdisciplinary approach to transitioning a patient from the acute care setting into the next level of care and making sure that the patient has everything that they need to be successful and not have to come back to the hospital multiple times. So I'm very excited to have joined the Project Red Solutions team. Very honored. Meeting Dr. Brian Jack was one of the highlights of my career last year. So thank you so much for that. And being part of this in something that I truly believe in is just an honor and a privilege. Thank you.
You're welcome. So let's get started. And I think that Emily has to advance the slides. So let's look at what it is we plan to cover today. And the first item is to look at the background behind transitions of care and why hospital readmissions are an important metric, an important measure, a proxy for where there are errors in the system. We're going to talk quite a bit about, I'll list, and Colleen will also talk about the transition checklist, which is sort of the left ventricle of the Project Red intervention. And then finally, we'll talk about applications and Colleen's incredible experience in case management and in looking at some case studies as these apply. So let's go on to the next slide, please. So why focus? The question would be, why focus on hospital readmissions? Well, first of all, hospital readmissions could be the result of a clinical change in the individual as he or she migrates from the acute care setting to the next level of care, whether that's home or a rehabilitation setting or home with home care, or even to a nursing home setting. It could also be the result of a poor quality treatment, that the treatment that was provided was somehow inadequate. The diagnosis wasn't correct, so the treatment wasn't correct, or overall poor quality treatment. An alternative explanation is that the individual was non-compliant, that the individual, the so-called patient, didn't engage properly with his or her treatment plan and simply didn't do what she was instructed to do, or didn't pay careful enough attention to her clinical symptoms and how she felt. The alternate is that it's a systems or a procedural or a process error in the transition. The wrong medication was ordered. The wrong piece of equipment was acquired. The equipment didn't show up. It was never ordered. The follow-on tests weren't ordered. There are a host of systems-based errors that could occur in these transitions that would result in deterioration of clinical condition warranting hospital readmissions. So these unnecessary or untoward hospital readmissions are an important proxy or evidence of these errors, these flaws in the ointment, so to speak. They put the patient at risk. They put the providers at risk by reintroducing that individual to the clinical environment, and they represent a waste of resources. When you unnecessarily readmit someone to the hospital or you get a do-over, you're doing something that could have, should have been done differently the first time. So let's go on to the next slide. There is a tremendous and growing evidence base for why transitions of care are so important. And the root of many of these problems are communication deficits, communications errors. So the good research in the US and the UK shows that following discharge, following the discharge of the patient from the acute care hospital, somewhere between 12 and 34% of the patients do not have their discharge summary when they go to see their follow-on appointment, when they go to their doctor or their other provider following up on their hospital discharge. They don't have access to their discharge plan. And then that gets worse as time goes on. And really, if an individual is sick enough to be in the hospital, they're sick enough to need follow-up care. So even in cases where the discharge summary is available in the post-discharge timeframe, a lot of those discharge summaries lack really important information, like descriptions of the hospital course, discharge medications, completed test results, pending test results. So an individual may have had a blood draw, phlebotomy, on the day of discharge, and we're waiting for those test results. The patient goes home. There's no information that the blood was drawn, that the tests are pending, and that the follow-on clinicians, the doctors or the nurses treating the patient in the follow-on time frame, there's no information that that person is waiting on these lab results, and there's no follow-on plans. So direct communication with post-hospital providers was decidedly lacking. Let's look at the next slide, please. So let's look at the actual checklist, and Dr. Morley will go over this as well. So here are the specific standards of care in transitions of care that we are promulgating as part of the re-engineered discharge. So we've broken them down into systems-based standards and interpersonal or behavioral-based standards. In the systems or process-based, the first is to provide a written after-hospital care plan that the patient understands. It doesn't do any good to give the patient a big, thick packet of information if he or she doesn't understand it. Next, please. Oh, and by the way, you can get this list. You don't have to scramble. You can get this list here at our website, and you can look at it as part of your follow-on. The second thing is that medication reconciliation and education has to take place at the time of discharge. This is especially true for international consumers, where they're crossing borders. They're leaving one country and going to another country, where the formularies may be different. The descriptions of the generics might be the same and the dosages, etc., but the formulary for a particular medicine, a particular diuretic may be different in the destination location. So there needs to be medication reconciliation. Next, please. There needs to be follow-up plan for outstanding labs and tests. Remember that if the patient was sick enough to be in the hospital in the first place, they're sick enough to need follow-up. And in that follow-up needs to include labs and tests, x-rays, blood draws, etc. Next, please. We need to arrange the follow-up appointments that the patient can keep. This shifts the burden of making these arrangements from the patient and the family caregiver to the discharge planner. That means scheduling the follow-on appointment with the cardiologist or the gastroenterologist or whomever, making the follow-up appointment so that the labs can be drawn and making sure that they're done at a time and on a day when the patient can actually get there. If the daughter-in-law is only available on Thursdays, it doesn't make any sense to make an appointment for the patient if she has to drive to get to the appointment. It doesn't make any sense to schedule that appointment on a Friday because the patient's not going to be able to get there. Next, please.
Irving, may I interject real quick?
Please.
The gold standard for follow-up appointment after a patient's been discharged from an acute care facility is 7 days from the time that they were discharged. So that first week, that's your big opportunity because a lot of the readmissions that we're seeing are happening within those first 7 days. So we want to
Yes.
make sure that the patient can get in to see at least their primary care physician within that golden time of the first 7 days. Most of the time when a patient is charged with making the appointments, and this has happened even with my own child, they call the physician's office and they say, okay, you know, I need to make an appointment. And they're told, oh, we have availability 30 to 45 days out. And that's way too late. The patient and their family do not know the correct words to say when, you know, oh, I was just in the hospital, I have to have my follow-up appointment. Even if we give them that scripting, they're not getting that action on the other end. Whereas if we at the hospital facilities make those appointments for them, we can facilitate that much more easier and more efficiently for the patient. And again, to Irving's point, making sure that you're arranging follow-up appointments that a patient can keep. Make sure that you're doing this in concert with your patients and their families. Thank you.
Points well made, well taken, Colleen. And another data point that I didn't talk about when we were talking about the evidence behind why monitoring and bending the curve of hospital readmissions is so important is that there's very good data to show that when readmissions occur, it is at least, I believe, 40% of the time, it's before the patient has even seen her had her follow-on appointment with her primary care doctor. So whether that's a corollary or a causal fact, but that's what the data says. And indeed, that first 7 days is so critical, which goes to the point of organizing post-discharge services and equipment. The patient may need a CPAP, BiPAP, a bed, a wheelchair, a walker, crutches, cane, oxygen, some follow-up equipment or services in their home. That should be all set up and arranged. And also, as we mentioned earlier, scheduled in a way so that there is somebody home and available when this occurs. We need to reconcile the discharge plan with any national or international standards. And for those international, the individuals in our audience who are not from the US, these standards might be different in the UK, in Turkey, or other places, but the reconciling these plans with these national or international guidelines is critical. Next, please. The summary of the discharge plan needs to be sent to the PCP, the primary care provider of the patient, within 48 hours. Even if it's not complete, even if we're still waiting on a cytology, or even if we're still waiting on a lab result, those documents need to be sent to the PCP so that he or she has a clear picture of what to expect when the patient appears on his or her doorstep. Next, please. And provide meaningful telephone reinforcement within 2 days after discharge. That means having somebody make the call who actually speaks the patient's language, who can interact with the patient effectively and determine if the patient is indeed on the mend, comfortable, or if there is wound discomfort, or if the patient still doesn't understand something about his or her medicine, or giving the patient a chance to ask the questions which he or she may not have been able to ask or forgot to ask before she left the hospital. So this is a list of the systems-based changes. Thank you. And here are the interpersonal or training-related standards of care that we want to focus on. Next slide, please. So next, please. The first, which is a major breakthrough in the effectiveness of Project Red, which is called TeachBack. And this is an interpersonal tool used in education where you provide the instruction, you then ask the audience, you ask the individual, the patient in this case, to repeat back to you what you just told them. It's amazing how many times this points out people's lack of understanding of what it was you just told them. I've used this technique with my children and my grandchildren a few times, and it is indeed amazing what they don't understand. What do you mean you don't understand something about every day? Determine, this is how you're going to determine the need for and the requirement for language assistance. If they speak enough to make you think they understand, but not really enough to understand what their diagnosis was or what their treatment plan is, then you need to recruit language assistance. You need to provide information about diagnosis, involving the family caregiver in the discharge process, and explain common problems in language they can understand. It doesn't do any good to say if the wound becomes inflamed or
Septic.
yeah, septic. It doesn't make any sense to say them. If it gets septic, give us a call. They don't know what septic means. So you need to either show them or explain it to them. Tender, hot or warm, itchy. That's when you need to call. Explain common problems and what to do if problems arise. And again, the complete list is on our website, which we pointed out here. Next slide, please. So let's turn it over to Colleen and have her talk about some of these case management principles and how they apply and some case study.
Great. Thank you, Irving. Appreciate it. So as president of the National Case Management Society of America, National Board of Directors, we have a definition of case/care management. And I'm going to just read it to you because it is very, it looks like it's not concise, but it gets a lot of information in here. So we say that case management serves as a means for achieving client or patient wellness and autonomy through our efforts of advocacy, communication, education, identification of service resources, and service facilitation. This case manager helps to identify appropriate providers and facilities throughout the continuum of care. So remember, we may all be in a hospital, but that patient has a whole journey ahead of them. And even when they're at home, they're still going through a healthcare journey. Okay. So throughout that continuum of care, while ensuring that the available resources are being used in a timely and cost-effective manner in order to obtain optimum value for both the client and the reimbursement source. We're also looking that the services are best offered in a climate that allows for that direct communication between the case manager, the client or the patient, and the people that will be servicing them in order to optimize the outcome for all concerned. Again, back to the overarching issue in healthcare of poor communication. So case management is developed and designed specifically to facilitate communication and accompany that patient along their journey, getting the services and the resources that they may need across their healthcare journey. Next slide. So the case management process, this is always, the biggest thing. Okay, how do you do what you do? Well, first we screen our patients. Not everybody needs a case manager, walking beside them. If you're in the hospital and you're just having an uncomplicated appendectomy, not necessarily going to need a case manager to walk you through that process. We'll be with you. We'll give you the information. We'll connect you with what you need. But there are truly people that need somebody walking hand in hand with them. And I'm thinking of our chronic condition management patients. I'm thinking of our oncology patients or our spinal cord injury patients, our neurologically compromised patients who've had strokes or brain injuries, things like that. These are people who need a longer trajectory with a case manager. So once you've got that screening and you've identified that population that's going to need further information and further interventions, then we do a full assessment. We do a head to toe, we do a scoping assessment of their entirety, not just their physical health, but we're also looking at emotional, we're looking at their financial ability, we're looking at the services that are available, what do they need, what can we get? We then stratify them in a risk stratification. So, who's our hotbed, our hot issues that we have to take care of. We then do a lot of planning. Case managers are in the hospital are sometimes referred to as discharge planners because we're planning that entire discharge. We're planning for the next level of care. We're planning for what's going to happen even after that. Once we get that plan in place, and that's not just our plan, that is the plan in coordination with the care team, and that care team includes that patient and those family caregivers. So everybody's involved in this plan. You come up with a plan that meets your patient's centered goals, not my goals, not the doctor's goals. It's what the patient and their caregivers are looking for. Great example, real quick. My mom was in a rehab facility. She had Parkinson's disease, stage 3, and was having a little bit of dementia. And the physical therapist wrote up this plan that, Patty will be able to walk 175 feet independently within the next 3 weeks. Well, Patty hadn't walked independently for over a year. She loved her little rolling walker thing that she could decorate and keep all of her stuff on. And 175 feet was just not ever going to happen. She wanted to walk 40 feet to the kitchen and 60 feet the other way to the bathroom and back to her bed. And so the physical therapist making that plan was not taking the reality of my mother's situation into consideration, nor were they taking Patty's goals into consideration. So that's what we do. We create patient-centered plans. The next step then is to implement those plans. We're going to find those service providers. We're going to have those conversations. We're going to, again, confer with that entire care team. What does this patient need in order to be successful at the chosen next level of care? We're going to follow up on that and make sure that T's are crossed, I's are dotted, that this patient who may be going home and needs some durable medical equipment, that's all delivered, that their follow-up appointments are made for them, that they have everything that they need to be successful in the next level of care. And then we're going to take a look at our process and our interventions with our patients, and we're going to evaluate that and see, did this work? You can evaluate it on an individual patient level, or when you get to my level of case management, you're looking at the process and the department as a whole for the entirety of the health system, maybe individual hospitals, maybe just individual units in the hospital. How is this case management process working? Do we need to tweak it? Where are our gaps? Next slide, please. So in principle, we're looking at a holistic approach. We're looking at each patient as a whole person. Medical, psychological, social, sometimes spiritual aspects will have an impact on the care that we give as well. So we have to take all of that into consideration and say, okay, looking at this person as a whole person, how are we going to meet their needs? And how is this going to affect our transitions of care? Why do we do this? We want to make sure that the patient's journey through the healthcare system is not fragmented. We want good handoffs. We want good communication. I don't ever want a patient calling me back and going, I couldn't get in to see the doctor because I didn't have transportation and transportation wasn't set up, or I didn't know how to get to it, which happens more times than you'd care to think about. In real life, we tear it down to those coordination tasks. We tear it down to the discharge planning, to the follow-up appointments, to the medication reconciliation, to the education and the teach back, because this active collaboration of the entire care team, like I said, doctors, nurses, social workers, pharmacists, healthcare professionals, and let's not forget the patient and their family or their caregivers. This is fundamental, all right? And it also helps to give us a better, more effective communication system, whether we're using electronic medical records or we're talking about interpersonal communication. These communication opportunities are helping to facilitate this collaboration and make a better transition of care. Next slide, please. And if you have any questions, please pop them in the Q&A. Some of the challenges in communication pitfalls or common pitfalls: miscommunication. Think about a really bad game of telephone. You're giving report from one person to another person to another person to another person. It starts out as one thing, it ends up as a completely different thing by the end of the game, right? Maybe there's a lack of information. Maybe the people that you're talking to just don't know or don't have access to that information. Therefore, that is a gap, right? Inadequate follow-up care. Do they have access to their primary care physician? Do they have a primary care physician, or do you need to establish a primary care physician? In their area, do they have access to specialist care? Is that why we have inadequate follow-up care? Or, like I said earlier, do we have a transportation issue? Do we have somebody that can drive them? Do they have access to public transportation? Under their insurance here in Illinois, we have our managed Medicaid plans have a built-in transportation benefit, but it's very, very difficult to access. You have to call 3 days in advance and fill out a form. And so making sure that we educate our patients on how to access the transportation that's available to them. And fragmentation of care. I was working with a patient once who lived on the border between Illinois and Iowa. She was seeking some of her care in Illinois and some of it in Iowa. And do you think any of those people talked to each other? Well, the answer was no. The only person that knew what was going on was the insurance company because they were getting all the claims. So the insurance case manager actually led that collaboration and that coordination of care and was able to bring all of those practitioners together at a table with her chief medical officer, and were able to resolve that fragmentation of care for that patient. And the patient had so much better outcomes afterwards because everybody was at the same table, hearing the same message, working together. And then resource limitations. If there's no resources available to meet the need that's identified, what do you do about that? How do you fill that gap? In cases where you've got patients who are suffering from food insecurity, I mean, do they have the ability to go out and procure food? Can you set them up with home meal delivery, or can you set them up with like a senior luncheon program? Understanding the limitations of your resources, and also helping to identify the community, helping the community identify what the resources that are needed in their area is one of the great things about this kind of an exercise, and looking at the practice of case management and the effectiveness of a case manager to go, hey, you know what, during that evaluation phase, we're looking at all these patients, and we have a huge population of patients that just don't have access to X. And then you're able to go to community providers and say, we've got this identified issue. Can we do something about it?
Can I insert a question here, Colleen?
Absolutely.
Would you address, please, the concept of patient engagement?
Oh, I could do a whole hour on that.
So we hear, both in America and elsewhere, we hear about the ideal being the fully engaged patient, and if the patients were really engaged, that the outcomes would be so much better. I personally think that's somewhat unrealistic, but would you address the issue of patient engagement?
Sure. Patient engagement, we can look at it from a couple of different things. Like you said earlier, Irving, you've got a non-adherent patient. Why is the patient non-adherent? And that's where we fail horribly as a healthcare system. We're not asking our patients what's going on. I did a project about 5 years ago where we actually created a questionnaire for our patients who were being readmitted to the hospital I was working at. And we asked the patients from their perspective, why were they being readmitted? I mean, it's a simple question. We go through a whole list of, were you able to get your medications within 24 to 48 hours? If not, how long did it take you to get your meds? Did you have transportation issues? How about any other kinds of social determinants of health? Childcare issues? Were you experiencing domestic violence? Things like that. Do you have a behavioral health component that was interfering? There was like 10 questions, but the last question, open-ended answer. Why do you think you got sick enough to come back to the hospital? And then after about a month, we started adding in the health confidence tool by Dr. Eric Coleman. And it says, on a scale of 1 to 10, how confident are you that you can take care of yourself when you go home? And you want to get at least a 7, and we were scoring at about a 5.9 for our patients. So they weren't confident that they could take care of themselves. The answers that we were getting back about, why do you think you were readmitted, was ranging from a patient with CHF coming back saying, well, you didn't cure me, which means that somebody did not educate that patient on the fact that CHF does not go away. It's like luggage, it stays with you forever. But then, I lost my medications. I didn't have transportation. I took my meds, but it really got annoying, and I didn't want to take them anymore because taking diuretic at 9 in the morning and 9 at night kind of disturbs your sleep pattern. The more interesting ones that came back to us were very indicative that our patients lacked health literacy. They did not understand what the care plan was, how to take care of themselves, how important it was. or the reasons that they were doing things. They did not understand how to take their medications because we weren't being very specific with them about it. There's a really great video from the American Medical Association on health literacy, and one of the little scenarios in it is there's a lady, she's got a little box of medication, and she says, she takes 16 medications a day, and she doesn't, they say to take it twice a day, but they don't say when. So should she take it in the morning, in the afternoon, or should she take it in the morning, in the night? So she just takes all 16 of them in the morning. That way she quote unquote has them, which of course we all know as healthcare providers that don't work for us. So I think that we can get to patient engagement. It's a process, but it's a process that we as healthcare practitioners and the interdisciplinary care team have got to invest ourselves in. I had a patient once that was readmitted 4 times in 6 weeks. And every time we sent him home, to your point, Irving, earlier, with about a ream of paper, 4 inches thick. He brought it in once, actually. Within this 4 inches thick was the Micromedics printout for every one of his 8 comorbidities, every one of his 15 medications, his discharge planning information about all the services he'd be receiving, all the brand new prescriptions for all of his 15 medications that had been switched from the little cute piece of paper to 8.5 by 10 pieces of paper. So, and we sent him home with that, and everybody was checking the box: education done, education done, education done. Just by giving him this pack of paper, they thought education was done. Hey, guess what? Guy couldn't read. We're sending him home with a ream of paper 4 times, and he can't read. And he wasn't going to tell anybody that he couldn't read because, but we didn't do a good job of assessing that. So finally he said to me when I was in his room, I was like, we got to figure this out. And, that's when he opened up and said, you guys keep throwing paper at me, and I got to tell you, it makes me feel stupid because I can't read this stuff. And, truthfully, Micromedics, I got a doctorate in nursing. I can't read it. So we need to be able to speak to our patients in a language that they can understand. There you go. All right, moving on. I'm off my health literacy soapbox now, but we can get to true patient engagement if we do it very patient-centered with a good eye to taking care of our patients and educating them and preparing them to be the owners of their healthcare. So some of the challenges that we have, well, increased readmission rates. I got a lot of work in on this since 2009, and that's one of the reasons that I wrote the book that came out just yesterday. Lots and lots and lots of good data, lots of great projects going on around decreasing readmission rates. And some places do a really great job of it. But hey, guess what? Overall, that number hasn't moved in 10 years. Why? Well, let me hypothesize for you. It's not the same population of patients that we were looking at from 10 years ago. We keep adding new patients into that, new diagnosis of CHF and COPD. And these are people who haven't heard our song and dance and aren't engaged patients versus our stage 3, stage 4, who have been through everything and are pretty much engaged and are pretty savvy at taking care of them. But guess what? Now they're moving into the end stage of the diagnosis. So they're going to be experiencing more exacerbations, right? So on this end, you're going to have more readmissions. On this end, you're going to have more readmissions just because they're in denial that they even have this condition and they don't know how to manage it. So the readmission rate, while we're doing a lot of great work, doesn't budge significantly at all. So other things, patient dissatisfaction. How dissatisfied do you think my patient who got discharged 4 times with 4 inches of paper was? He did not feel like he was being heard. He did not feel like he was being navigated actively through the system. We were just throwing paper at him to get him out of the hospital. Higher healthcare costs. Well, here in the US, you get paid for the initial admission, and then every readmission after that within the 30-day period, you don't get paid for. So this guy who was readmitted 4 times in 6 weeks, well, we didn't get paid for 2 of those because they were within the first 30 days. And then at the end of the year, Medicare goes back in and takes a look at all of your numbers and stuff like that, and then slaps a penalty on top of that of up to 3% of your Medicare reimbursement. And 3% of $2 billion is a lot of dollars. And then adverse health outcomes. Let's not even talk about what it looks like from the hospital side. Higher healthcare costs, yes, that impacts everybody. But let's talk about the adverse health outcomes. You've got a patient coming back into the hospital, back into the hospital, back into the hospital. Higher risk of infection, higher risk of medication errors, higher risks of contracting something else, and they go home and they're still not able to take care of themselves. And they go home and they're still not able to take care of themselves. The morbidity and mortality for a patient who's been readmitted into the hospital is much higher than somebody who has not been readmitted to the hospital. I have those numbers in a presentation. I don't have them on the top of my head, but it's incredible that we're looking at. We can't just look at it from a financial perspective. We can't just look at it from a quality perspective, but we truly have to look at it from the patient lens and say, what are we doing for our patients to make sure that they can be healthy and successful, healthy to the highest level that they can achieve. Next
Yes,
one.
and there's, to your point, Colleen, there's lots of data in both the United States and the UK, less so other places, but there's lots of data to show that hospitals are dangerous places. The technical term is iatrogenic injuries. These
Yep.
are injuries as a result of the treatment itself, and they range from minor to death. And they are significant in healthcare, in hospital settings. So keeping people out of hospitals is a public service.
Right. Well, there's a really good, it's an older study, but it's still impactful. It's called How Dangerous is a Day in the Hospital. So Google that. All right, next slide. All right, evidence-based. Oh, well, at the time of discharge, we're showing that 27% of our patients don't receive verbal instruction about their new medications. Why? Because we're printing it and we're handing it to them and expecting them to do it themselves. 48% of them were not told the reason for appointments. I remember one patient, I said, you know what, we've made all these appointments for you, why didn't you go? And she's like, I just saw a whole bunch of doctors. Why do I need to see any more? 55% were not given instructions on post-hospital disease self-management. This is true because we're handing them paper and we're expecting them to read it, and it's written in a language they don't understand, which is called medical ease. It needs to be written in at least a 3rd to 5th grade reading level and in their preferred language. And there's no guidance on red flag signs. So like AMA, not AMA, the American Lung Association, the American Heart Association put out these great little stoplight reports or stoplight things that show you, okay, if you're feeling in a green area, you're good. You don't have to call the doctor. If you're in that yellow area, you should call the doctor. And this is what the yellow area looks like. Maybe you put on about 2 pounds. If you're a CHF patient, a little short of breath. But then it's like, if you're in the red section, you should go to the hospital, not the doctor. And our patients are not receiving that guidance. And this is just a very simple, easy visual for our patients to be able to put on the refrigerator and go, oh, let's see where I check in today. Go ahead. So what do patients recall? Well, they recall their inpatient experience because, that's what they just lived through. They can tell you the reason why they were in the hospital. Well, only 58% of them. Well, I was in there because of my heart. Okay, what does that tell you? How many different diagnoses do we have for heart stuff? 50% of them can recall their treatment plan. What's going to happen to me after I leave the hospital? And only 43% recall any medication changes because they're looking at the bottle and they're going, it's going to be printed on there, but it's not. And oh my goodness, let's talk about going into a patient's home as a home healthcare nurse and finding somebody with like 6 years worth of pills and different formulations and different, what's the word I'm looking for? Lost it. 120 micrograms versus 100 micrograms, right? Oh, well, I'm going to finish this one up because I paid for it, or I'm going to, and they're expired. Oh, but I paid for those. I want to keep them just in case. Like, no, it's not going to work. So, and then follow-up care. unfinished business. We talked about 25% of discharged patients require that additional outpatient workup. And that's not necessarily an outpatient workup per se, but it's a case of, they should be seeing their doctor for follow-up to, tweak those meds if they need to be tweaked, or to make sure that, T's are crossed and I's are dotted. 30% of those outpatient workups are never completed. And then if you look at the research about people actually attending their follow-up appointments, even if they're scheduled, that's only about 40%. We scheduled, as a project, we did 75% of our patients were scheduled with outpatient physician visits after or post-discharge, and only 40% of them actually attended. You can lead a horse to water, but we continue to work with those patients to get them to that patient engagement sweet spot, right? Next one. So what are some of the primary objectives that we had to look at? So we needed to improve the discharge process. Simply printing things and clicking off a box that says education given might meet the needs of any kind of a certification or a survey that you're going through, but it certainly does not meet the needs of your patient. We need to streamline and standardize those tests. We need to make sure that the patient is being discharged from the hospital in a safe, comprehensive, and clear way. We need to reduce hospital readmissions for a whole bunch of different reasons, not just the financial, but also the quality of care. And again, to both Irving and my point, hospitals are not the safest places in the world, right? All right, and we need to enhance those patient outcomes, making sure that our patients are getting the absolute best overall care that they can to achieve that highest attainable level of function. Next slide. All right, so a couple case studies. Penn Medicine, Chester County Hospital, 257-bed complex in Westchester, Pennsylvania, part of the University of Pennsylvania Health System, was one of the 10 hospitals that were involved in AHRQ's rollout of the Project Red toolkit. They started out with one unit, now it's used hospital-wide. And Carly Meister says, we initially initiated RED for congestive heart failure patients on our telemetry unit and found it to be extraordinarily successful. Without adding additional nursing resources, they achieved a 50% reduction in readmission for their CHF patients on that tele unit. So then they took that and they rolled it out through the rest of the facility. And after that hospital-wide implementation, that readmission rate for congestive heart failure is now between 14 and 16%, which is significantly lower than the national average. They then used it on their chronic obstructive pulmonary disease, or COPD patients, and dropped that readmission rate from 19% to 11.7%. And let me tell you, that's a significant reduction. Next slide, please. Nacogdoches Memorial Hospital, again, 216-bed level 3 trauma center in Nacogdoches, Texas, saw readmissions drop from 18.6% to 16.6% just in the first 6 months after implementing Project Red's toolkit. Jessica Stewart says that the toolkit helped reduce the readmission rate and built momentum among the clinicians to improve the patient discharge process. Isn't that great that it gave them the kick that they needed to look at their whole discharge process and go, that's broke, that's broke, that's broke, let's fix it. As an interdisciplinary care team, they took the RED toolkit and not only implemented that, but have been working to refine the discharge process by increasing the interaction between the multidisciplinary care team, most notably the physicians and the social workers, also making sure that they're providing their discharged patients with certain medications and transportation to 2 follow-up medical appointments. They're also working with the staff at area skilled nursing facilities to talk to them about care transitions because they need to lower that hospital readmission rate. And a lot of their readmissions were coming from the skilled nursing facilities. Middle of the night, patient starts, having some issues, call the doctor, send them to the emergency room when they could, in fact, maybe have been treated in place. Next slide, please. And then Dignity Health System, 3 California hospitals used Project Red toolkit to reduce readmissions. Bakersfield saw 30-day readmissions for Medicare patients drop over a 6-month period from 25% to 11.3%. Yes, so exciting. I love that one. in all payer 30-day readmission rate dropped to 6.5% from an average of 7.5%. So that's incredible. At their St. Mary's Medical Center Trauma Center in Long Beach, they introduced Project Red for their heart failure patients because we know CHF, COPD, AMI. That's all we talk about these days, right? Readmission rate for this population dropped to 7.7 from a high of 22.2, and the all-cause readmissions dropped to 5.7. And then in their San Francisco St. Mary's Medical Center, their readmission rate dropped by more than 20% to 5.5 from a 7.6. So significant drops in readmission rates using the Project Red Discharge Toolkit, and giving fresh eyes to the way that we educate, collaborate, communicate, and discharge our patients. Next slide. That's all I got for y'all. I hope it's been helpful.
That's terrific.
If there's any questions.
I'm going to ask one of the first questions.
Oh, great. Go for it.
So we do have some questions in the Q&A. I see them, but I'd like to ask the first of the questions, if I may, Colleen. So there's been a lot of buzz in the healthcare space about analytics, about predictive analytics and this artificial intelligence. Some of the things that talk about artificial intelligence really aren't artificial intelligence, but putting that aside, analytic tools. You mentioned at the beginning of your presentation, Doctor, that one of the first things that your case managers, care managers do is to triage or organize the consumers into groups, because there's certain groups of consumers, certain groups of patients, certain groups of clinical diagnoses that are traditionally more at risk for problems. Can you talk about, are there any tools that are being used to help organize or predict which consumers, which patients are going to have higher levels or are more at risk in the discharge phase?
Sure. Traditionally, this has actually been a focus. I used to work in managed care a long time ago, and we were starting out with stuff called predictive modeling. So we take all the claims data and we run it through, and we're able to stratify by, people that use the emergency room a lot, or readmitted patients, or high claims dollars. So that's one way of doing risk stratification. Recently, though, through the use of AI, there have been a lot of the established electronic medical records that are putting tools in place to be able to do a little bit of inpatient risk stratification and take a look at, if the patient is using the same hospital over, a significant period of time, looking back at the entire medical record and saying, hey, this patient's been here 12 times in the past 18 months, and this is their diagnoses and this is what's happened to them, and kind of give us a risk strat tool. This is something not necessarily done on the inpatient side because we're working at such a fast pace. It's like, okay, what are we going on to? And we're flagging patients, as a 30-day readmission, but that's about all that we can do with the current technology. Lots of work being done in this area. I know this because I've actually been asked to take a look at some programming and some concepts behind it. So it is a growing area, and I think that we'll see a lot more growth in this area, where we can expect great things to come out to help the acute care case manager actually have that 50,000-foot view of the patient and appropriately figure out where the patient is, in their patient engagement journey, maybe, but also in, what did we miss? What are the gaps? And there's some of the AI out there that can actually scrape through the medical record and identify social determinants of health gaps and things like that. So I think the future is very, very bright for that.
Let's do a program on that at some point in the future. You had mentioned the final phase in the case management process. I found that slide very informative. You said that in the final phase is the evaluation phase. In that case management process. Can you give us and the audience an example of some of the measures, some of the metrics that you use to evaluate the effectiveness of this case management process?
Well, they could vary from place to place depending on what's important. In my world right now, what's important is making sure that we've captured the social determinants of health data and closed those gaps, because we know that 80% of a person's healthcare experience is related to social determinants of health impacted areas, and only 20% is impacted by the quality of care and access to care. So making sure that we've got, good housing, access to food, access to transportation, things like that in place really will help our patients have a better healthcare experience. And then also we're talking about their behaviors as well, right? Smoking, risky behaviors, that's all part of the social determinants as well.
Right. And overlaps with the patient engagement feature that we
See,
talked
it's
about.
all interconnected. It's
Right,
all
it is.
interconnected.
It's
So, that's just one
interconnected.
example of one of the metrics I look at. Some of the other metrics I look at, again, like I said, you can look at it based on, an inpatient unit and how effective what's the length of stay looks like for this population of people, or you could drill it down by diagnoses and look at length of stay. You can look at avoidable days. You can look at excess days. You can look at complications, comorbidities. It goes on and on. However you can slice and dice the data that's coming out, I would suggest taking a look at it and deciding whether it's useful for your program, because everybody's program, while they're pretty much similar, you may have a different focus. When I was at one hospital, we had a very large ESRD population. And so we had to look at different metrics there to make sure that our end-stage renal disease, sorry.
Thank you.
But we had to look at different metrics as opposed to if we were looking at a patient with chronic obstructive pulmonary disease.
Yes,
Two different
yes.
body systems, two different trajectories. So, making sure that we looked at it from a population-specific lens.
Great. Emily, I see there is questions in the Q&A. Can you share them with us?
Sure. The first one is, how long is the average length of stay for readmissions, and what are the costs to the patient and the hospital?
The average length of stay for readmissions, I don't have that data because it's dependent on the reason for the readmission. So here's the thing. 80 million years ago, when we first started on readmissions, we were trying to figure out what the definition of a readmission was. And, they were looking at CHF, COPD, pneumonia. So a lot of people thought it was just coming back in for the same diagnosis, same or similar diagnosis. So if you're coming back in for CHF, then it counts as a readmission. Well, about a year into it, everybody was operating under that assumption. But then a year later, no, readmission is coming back for any reason. So you could have a readmission for a patient, patient gets discharged with CHF, gets in a car accident on the way home, ends up back in the hospital with a busted leg. That counts as a readmission. So it's not necessarily all related to each other. So the average length of stay for readmissions will vary greatly depending on your facility and your patient population. The cost to the patient in the hospital, again, for the hospital in the US, the index admission, that's what we call the first admission, that gets paid for. Anything after that, any admission that happens after that for 30 days does not get paid for. And then at the end of the year, they take a look at your numbers and they can penalize you. I'll be nice. Penalize you up to 3% of your Medicare reimbursement.
Yes.
So those costs can be incredibly significant. Again, very dependent on your facility. I do, however, I pulled up my old presentation. Acute hospital admissions for Medicare, $29 billion in Medicare spending, with the Medicare population predicted to rise to 170 million by the year 2030. In 2019, 82% of hospitals in the hospital readmission reduction program received readmission penalties of up to 3%.
Yep.
CHF, current cost of care for CHF overall, 43.6 billion with the B
right.
dollars a year, projected to hit $69.7 billion by 2030. And it's 2024, so it's right around the corner. For COPD in 2020, $49.0 billion for care costs. And we're looking at a 52.6% increase in those costs of care within the next 10 years.
Yes. So we actually have looked at some of these data for clients, Colleen.
Mhm.
And in one state where we analyzed the cost of hospital readmissions, it was $15,900 plus. And in another state, a lower cost state, it was slightly under $15,000 for readmission.
Mhm.
And the ALOS range, the average length of stay ranged from 4 days to 6.2 days. So these lengths of stay are, as you said, Dr. Morley, keyed or contingent upon why they're being readmitted and how severe the situation is, how the underlying organic disease is. But as you say, a readmission could be for something completely distinct from the discharge. So
Right.
we are flat out of time. See how much fun we can have with a
Yay!
topic when we dive into it. We have other questions that we didn't get to, but we will summarize these, and Dr. Morley and I will try to respond to them in the follow-on. So we're deeply grateful to Colleen for this excellent presentation and conversation. Thanks to everyone for attending, and look for an email from Project Red Solutions with the link to the recording of this program and others. We encourage you to share them, share these resources with your colleagues or whomever else you think may benefit. Be on the lookout for other programs in 2024. We've got 2 more scheduled on this International Transitions of Care series, where we're expanding on this topic, examining how transitions of care are managed in and between countries and within countries. Be on the lookout for these. And please visit Project Red Solutions to access today's program and our other resources, other webinars, articles, and the AHRQ toolkit, and take advantage of the Project Red principles through training, implementation, consulting, and measurement for better transitions of care. Thank you, and have a terrific rest of your day.
Have a great one. Thank you for your time.